Pleasant day, fellow learners. I'm back, your fact check buddy. Here's your mentor Ray once again. Before anything else, allow me to thank all of you guys for sticking it out with our YouTube channel. Thank you so much. Thank you for the opportunity to have served all of you through our videos in our YouTube channel, and thank you for continually watching all of those videos we created. Me and my team have really spent sleepless nights conceptualizing and coming up with all those videos that our goal should be worth your time watching. Okay, so without further ado, once again, I'd like to share with you concepts that you have to remember, and this is under QuickFix 20. Okay, but before that, allow me to express my gratitude for all of those who greeted me on my birthday, from organizations like Ornap Iloilo Chapter, from my Derma Bello, okay, from colleagues like Rachel Venson, and of course, my coworkers at the office, to Mom Glo, who sent a cake, and of course, Miss Selena and Miss Joanne, who acted as a mermaid. We had just a backyard barbecue afternoon, but food came in that started with a breakfast. Somebody gave me a happy birthday breakfast, and then somebody gave me my favorite brass with the Mercedes. Okay, and of course, a lot of gifts came in. Some even dropped by to say hi and greet me, from pizza to cakes to oh, this is roasted pig. Okay, that's from a popular restaurant owned by a famous celebrity here in the Philippines. Thank you so much for all the gifts, and most especially the love. Okay, and of course, there's a fruit basket. I love this because it's dipped in chocolates. It's from Mom Glenda. And my colleagues at the Holy Angel University, from my mentor, Prof. Dang, Din Al, Doc Pre, Anoy, and of course, Doc Choi, and my niece and my nephew sent me another roasted pig, and of course from Sir Winston and the rest of the gang at the office. Thank you so much. I can't thank you enough. Well, Quick Fix session should have been live streamed on April 10, but I had COVID and was diagnosed with COVID on March 27, and so I have to undergo treatment, and it actually progressed to critical COVID pneumonia. I thought I would not make it, not once but twice. If you would notice, this is me, and all sorts of machines were in my room, from hemodialysis machines. I had hemoperfusion, then I have all sorts of monitoring devices, and it's such a good thing that my oxygen saturation was able, I was coping, and I was able to maintain it within the normal range of above 95, but at a very high oxygen perfusion level that even went to 100% with a high flow nasal cannula. You can just imagine, at 40 liters per minute, 5 liters per minute could just be irritating to the mucosa of our nose, but 40 liters per minute, wow. But that was the level of oxygen that I had when I had COVID pneumonia. But fortunately, because of a team of excellent, caring, and God-fearing healthcare team who took care of me, from the nurses to the doctors of the University Medical Center of the De La Salle Health Sciences Institute. Thank you so much for the second life I'm enjoying now. And so, to make the long story short, I got discharged after, well, several weeks. And of course, what greeted me are these nice messages. One came from Darla Garcia. Hello, Sir Ray. I'm glad you're okay na. Na-miss ko yung quick fix sessions nyo. She says, she missed my quick fix sessions. I'm your student, February batch, certified kadugyot. That's the name of our group chat. I took my exam last Saturday, and 1 hour and 15 minutes, 76 items, 24 SATA USRN na po ako dahil po sa inyo. Sobrang thankful po sa Gapus. She's saying thank you to RA Gapus. Okay, and then she says here, mula nang nag-start ako with Gapus Review, tumaas po scores ko. share ko po yung YouTube channel nyo sa friends ko. Super effective. Pati yung books ninyo, sir. Favorite ko yung NCLEX 311. She says, among all my books, her favorite is NCLEX 311. So, another feedback from Fiona Louise. You are truly God's symbol of miracle. This is no doubt because of your good heart. Stay healthy. You're such an inspiration, Sir Ray. Somebody said, thank you so much again, sir. They are all watching our YouTube videos. And this is the book that Darla is talking about early on. It's NCLEX 311 that contains 311 functional concepts for the NCLEX RN. So, before we get the ball rolling, may I invite you in my new program. It's a 45 days power pack. Okay? Exclusive NCLEX RN test preparations or review classes starting on September 11, 2021. So, the classes that will start on July 12, all seats are taken. Sorry, guys. The classes that start in August also, all seats are taken. And those classes are with the GAPUS mentors and, of course, me, myself. Now, the September 11 NCLEX exclusive virtual bootcamp with Ray Gapus is open to enrollment. And we now have a couple of enrollees already. So, the duration is from September 11 to November 15. It's going to be from 9 a.m. to 1:30 for Philippines and India. And 6 p.m. to 10:30 p.m. for those who are residing in California. The coverage will be functional concepts on the NCLEX RN, including all trends and updates utilizing an all-new method of instruction. It's truly new. The package includes all learning tools, including 3 books, but courier fees for the books are excluded. To register or for inquiries, click the link provided in the description box or on the announcement message, which means you have to send me an email if you want that slot. Okay? So, join us in this mission. Our goal is to provide free NCLEX application and review to 100 nurses. And to help us achieve this, just watch and finish the ads in our videos. That's all I'm asking of you. We have, for our next batch of scholars so far, we have 7. Okay, and we are still waiting for some to join us under our scholarship program. So, we have so many scholars that have made it already on the NCLEX. And for this upcoming batch, we have 7 so far. But we are still screening the others who just sent in their application message through email. Okay, so once again, so you can help me to provide free NCLEX RN application and review to 100 nurses. Okay, so far our total, I think we're now on, so 80 plus 7, 87. Okay, so we're 13 short of the 100, which is our quota, and we would want to achieve that before the year ends. And to help us achieve this, just watch and finish the ads in our videos. So, for those of you who may want to support the scholarship, please do get a copy of my book. The title is inspired by my experience with COVID, but this is not about COVID. This is about collaborative virtual instructional designs for teaching and learning nursing. This is a good gift you can send to somebody who is teaching at the university. If they are teaching nursing, so this is the book for them, and it's available in ebook form at Amazon. Please get your copy and support our scholarship program. Thank you so much in advance, and may God bless you more. So, reminder, those of you who have questions, send in your question through this email, mentor.raygapos@gmail.com. And for those of you who have yet to subscribe, those who will subscribe will shut down the NCLEX at a minimum number of items of 75 and pass the test. Okay, those who will subscribe and share it to at least 10 of their friends, if you share YouTube channel to at least 10 of your friends, then you will spend less time answering questions on the NCLEX. That's my prayer for all of you guys. So, without further ado, let's begin with session 20, the long delayed session 20. But most of you would be asking me, would the trends that I'm going to discuss in session 20 would still be applicable for the upcoming NCLEX? Of course. Okay, of course. This is forward moving. Okay, so this should cover enough concepts for those who are taking the tests in the coming weeks or months. Here we go. So, first and foremost, shout out to our passers, Ginny Corameng Bulong of Mariano Marcos State University, who passed the New York Board of Nursing last June 23, 2021, and she sent a pizza at the office. Okay. Thank you very much for the pizza. Wow, we appreciate it. And for those of you who have yet to send in their happy birthday pizza, we're still accepting. Of course, I'm just kidding. Thank you very much for the love, the greeting, and you remembering my natal day is more than enough compliment for me, guys. You're here, not just here. Okay, and of course, passer for our HAAD review. That's the Middle East examination for the permit to practice. Diana Desyesan Kapinpin of the University of Cordilleras for passing HAAD-R in Abu Dhabi last June 22, 2021. Now let's talk about our first concept, and this is prioritizing. Okay, so here's a functional concept. A client who exhibits tremors which indicate a complication is a nursing priority. You have to remember the phrase which indicate a complication. Therefore, if tremors that is expected in a specific condition occurs, then that's not a reportable manifestation. So that is not indicative of the development of a complication and is therefore not a priority for the nurse to evaluate. I'll give you an example. Fine hand tremors is commonly found in patients with hyperthyroidism. So you don't have to report that. Okay? You will just need to document it. Now, coarse hand tremors really comes in patients who are having alcohol withdrawal syndrome or delirium tremens. So you don't have to report that to the physician. That comes with the disease. It's expected. But the moment that your patient who's taking lithium carbonate develops fine hand tremors that progresses to coarse tremors, then that's indicative of lithium toxicity. Remember, it should be fine hand tremors that progresses to coarse hand tremors, because in a patient who's taking lithium, fine hand tremors could be an expected side effect. It becomes indicative of an adverse effect if it progresses to coarse hand tremors. So don't forget your different types of tremors. Okay? So let's move on. Let's try answering a sample question. So which of the following clients should the nurse consider as priorities for evaluation? Select all that apply. Let's go through it. A client on lithium who develops fine hand tremors to coarse hand tremors. I just told you a while back, this is indicative of lithium toxicity, so we put a check. This client is your priority for evaluation. A client with ascites exhibiting bird wings, muscle contraction with flex wrist when the arms are outstretched. Okay, so this is your flapping tremors or liver flap, and it's found in patients with hepatic encephalopathy. So always remember, when you see the word ascites, that means accumulation of fluid in the abdomen. So what should be the first thing that comes to mind other than the image we see in front of our mirror? Okay, of course. Okay, it should come to your mind that the patient could be suffering from liver failure, and that the condition is worsening if they exhibit flapping tremors. Okay, so yes, we put a check. And then number 3, a post-thyroidectomy client with hand tremors. This is indicative of a complication post-thyroidectomy. Remember that the parathyroid glands are located behind the thyroid, and so therefore when the thyroid glands are removed, there could be a potential for accidental removal of the parathyroid gland, which leads to decreased parathormone. Decreased parathormone leads to decreased calcium. Decreased calcium leads to tingling sensation around the lips, plus your Vostick sign and Trousseau sign, meaning Vostick sign, percussion of the facial nerve will lead to facial muscle twitching on that side, and then carpopedal spasm, that's your Trousseau sign, that comes with tremors, and those are all indicative of a complication. And the dangerous thing about hypocalcemia is that it could potentially lead to laryngospasm. Therefore, you need a tracheostomy set at the bedside in anticipation of a potential laryngeal spasm that could lead to airway obstruction. So we put a check for number 3. A client with Parkinson's disease having resting tremors, that is expected. Unilateral or bilateral resting tremors or pill rolling tremors is expected in a client with Parkinson's disease. So that's not something that we need to prioritize. A client with multiple sclerosis exhibiting intentional tremors. Intentional tremors, something that occurs when the patient is using the the fingers and the hands, then that's the time that the tremors would occur. So that's typical of patients with multiple sclerosis. Therefore, there's no need to prioritize it. A 1-week-old infant with jittery arms and legs while crying, so there could be tremor-like movement of the arms and legs, and that's normal in the first 2 weeks of life, especially when babies cry. So we put an X. So there you go. The answers are 1, 2, and 3. Now here is your functional concept for that question. Tremors are most commonly caused by, remember, saline, okay? Stress, aging, low blood sugar levels or hypoglycemia, increased intake of caffeine, including coffee and chocolates, and muscle fatigue. So remember your saline, that causes your tremors. Now, there's a form of tremors called essential tremors that affects both hands and the arms, occurring during activities and while at rest. Now remember, essential tremors could occur during activities and while at rest. And about 50% of cases of essential tremors are linked to a genetic risk, but the exact cause is unknown. Now, let's summarize what we learned. What are the different types of tremors and the associated conditions? Muscle tremors after thyroidectomy, we think of hypocalcemia. Resting tremors, think about Parkinson's disease. Intentional tremors, think about multiple sclerosis. Flopping tremors, think about hepatic encephalopathy. Fine hand tremors, think about hyperthyroidism. Coarse hand tremors, think about delirium tremens. And fine hand tremors progressing to coarse tremors, think about lithium toxicity. That's the way to do it. After going through it, after analyzing questions, then summarize. Remember, when you analyze, just do it moderately. Because as they say, too much analysis leads to paralysis. When you get paralyzed, you wouldn't know what to do next with a question. Okay, so let's move on. Now, for those of you who have yet to subscribe, like, and share our channel, you are invited to, come on, log on to Gapos Mentors, hit that like and subscribe and bell notification buttons, and share our videos to your friends, and pray that they will pass if they watch and listen to our video, and they will shut down at a minimum item of 75 if they don't skip the ads, because that's for our scholars, and if they help by supporting, they can help support the channel by getting a copy of my book from Amazon. Okay, so here are some feedback. Thank you so much, sir. You are a big help to us. She's watching QuickFix number 14. I learned a lot from you, sir. Thanks for the help. Once again, QuickFix 14. Thank you, Mentor Ray. And she is watching QuickFix 13. The QuickFix videos are really doing so well for those who just recently passed the test. And I hope that you share it. Keep on sharing it to your friends so that we can help them, especially at this time of the pandemic where we have to save every single penny that we have as extra, right? Okay. So here's one of the greatest feedback I receive after my discharge from the hospital. And he says, "Sir, salamat po sa mga review nyo." And that's in Tagalog. And he says, in English, that's, "Thank you so much for your review. In YouTube, the QuickFix videos, talagang marami akong natutunan." He says he learned a lot. Nakapasa po ako and he passed. He was not my student in my formal class. He just watched the QuickFix video. Way to go! And he passed last May 24, 2021. And he says, "Isa po sa lumabas sa akin ay ang valerian na sabi nyo ay magkatunog sa Valium. Sana po marami pa kayong matulungan." So, he said, one of those items that came out, and this is the reason why I covered his picture and his name, because he's not supposed to talk about what came out. But maybe out of excitement. Come on, let's protect our colleague. Anyway, he was just so excited to tell me that one of those I'm emphasizing, valerian, which is an herbal remedy that's considered a sedative like kava kava, and that has a Valium-like effect. Okay, they should not be given together, because if given together could lead to respiratory depression. And he remembered that. Thank you very much, Fern. Okay, that's a nickname, I suppose. And on to our next topic, and this is about delegation. Okay. So always remember, when delegating a task, consider the scope of practice required for the task, complexity and predictability of the task, potential for harm, the level of critical thinking required to perform the task. Okay, let's try answering a sample question. Which of the following tasks can the RN delegate to the LPN? Don't forget delegation from the RN to the LPN. If you may want to go over principles of delegation from the RN to UAP, please do watch QuickFix videos 17, 18, 19. Now, QuickFix video number 20 would be dealing with delegation from the RN to the LPN. Now, what about the LVNs? Well, in some states they're called LVNs, licensed vocational nurses. In some states they're called LPNs, licensed practical nurses. Administer heparin, only the RN can do that. Okay, these are medications classified together with your chemotherapeutic agents classified as high-risk medications. Only an RN can administer that. Now remember, your heparin is an anticoagulant, and it's given either subcutaneously or it's given IV. And the most important thing that you have to check for a patient taking heparin would be the partial thromboplastin time and the international normalized ratio, which means you have to know the normal PTT, which is 60 to 70 seconds. For the international normalized ratio, multiply the upper limit, 70 seconds, with 3, so you get 210. If the PTT of the patient exceeds 210 seconds, then the patient is at risk for bleeding. And you may want to stop the next dose of heparin and then check again the PTT. And then if the PTT of the patient is still beyond 210, then you will need to stop giving the medication and refer the patient to the physician for the order of your antidote, which is your protamine sulfate. Okay? Provide independent client teaching. No, only the RN can do independent client teaching. Okay? Reinforcement client teaching could be done, but not necessarily independent client teaching. Document client admission, no. Administer oral medication, yes. The LPN can do that. Monitor blood transfusion, yes. But only an RN can initiate blood transfusion. Change wound dressing of a client, yes, they can do that. Okay, so RNs can initiate and administer blood to a client, administer high-risk medications including heparin and chemotherapy, give meds through intravenous and IV push, monitor and titrate medications independently, and perform tasks that may be performed by the LPNs and the UAPs. LPNs, on the other hand, can assist the RN, that's a key word, assist the RN, assist in collecting data and monitoring client findings, and reinforce client teachings together with delegating to UAP. Now, LPNs can administer oral medications, enteral fittings, give nasogastric tube fittings, and check NGT patency, change wound dressings, monitor blood products but not initiate it, perform tracheostomy care and suctioning, and insert urinary catheter. LPNs with certifications, meaning they had further trainings, can monitor and maintain IV infusions, administer IV medications through piggyback, and remember this, LPNs cannot administer high-risk medications. They cannot administer IV push. They cannot titrate medications. They cannot independently provide patient education. They cannot perform or document admission or discharge of patients. Now, having that in mind, let's have another sample question. Which of the following tasks can be delegated to the unlicensed assisted personnel? Now, you're talking about UAP. If the LPN cannot administer your high-risk medications, more so for your UAP, so administration of heparin is an X. Check the vital signs, they can do that, but the initial vital signs should be done by the RN. Monitor intake and output, yes, they can do that. Routine monitoring. Document client admission, no, they can't. Discharge a client, no, they can't. Perform phlebotomy, yes, they can, provided they had the training. Okay. Now remember, UAPs can perform phlebotomy except arterial punctures. They can check vital signs and monitor intake and output too. So UAPs cannot perform assessment and patient education, and they cannot delegate tasks. They cannot administer medications, tube fittings, or change wound dressings. Okay, for those of you who want to review the concepts of delegation and assignment, we have a video that deals with that. Kindly look through it in our web of videos in our YouTube channel. And for those of you who have yet to subscribe and you're watching this now, please hit the subscribe and bell notification button so you'll get notified when we upload videos regularly on a weekly basis. And if you share to at least 10 of your friends, you're going to have less time in answering a minimum number of 75 items and eventually pass the test. Now, let's talk about this condition. I'd like to share with you, class. You have to remember this. For whatever reason there is, your guess is as good as mine. Okay? So let's talk about Myasthenia gravis. Now, when you have the word asthenia, it simply means muscle weakness. So Myasthenia gravis simply means there's muscle weakness. In essence, okay, you have to ask yourself what could have caused the myasthenia and what could be a common presenting manifestation. So the exact cause is unknown, but it's believed that it could be due to an autoimmune reaction that leads to a deficiency in acetylcholine receptor sites. Now take note that in myasthenia gravis, the area that is involved is your myoneural junction. It is the point at which the brain gives out the signals, and it's supposed to be transmitted by neurotransmitters like your acetylcholine, and it should be received by your acetylcholine receptor sites in the muscles. Now, what happens in myasthenia gravis is that the brain sends the signals, acetylcholine carries the signals, but you have a deficiency of the receptor sites. Therefore, since the muscles are not getting enough signals, they are not contracting, and so they have grown weak. That's the simple way of remembering it. And then, because they've grown weak, eventually it's easy for them to be pulled down by gravity. Hence, they have drooping of the eyelids, which could be unilateral or bilateral. This picture is from Creative Commons, okay? Now, myasthenia gravis involves deficiency of acetylcholine receptor sites. That's an important phrase for you to remember. Deficiency of acetylcholine receptor sites. Because if you just have deficiency of acetylcholine, then that could be associated with Alzheimer's disease, because acetylcholine is the neurotransmitter responsible for preservation of memory. So if you are deficient in acetylcholine, you're having Alzheimer's disease. But if your deficiency is going to be on acetylcholine receptor sites, then that's going to be myasthenia gravis. Okay? In myasthenia gravis, muscle weakness leads to double vision and drooping of the eyelids. These are the first signs and symptoms. So the muscle weakness actually begins on the face going down. So that's called descending paralysis. Okay? Your Guillain-Barré is manifested by ascending paralysis from the legs going up, and sometimes it's occurring at the same time from the neck going down, from the legs going up. So you have mixed type of muscle weakness. That's in Guillain-Barré, not in myasthenia. Myasthenia, it begins on the face, double vision, drooping eyelids, difficulties with speech, and absence gag reflex. You know for a fact that your gag reflex, okay, is related to the functions of cranial nerve 9 and 10, your glossopharyngeal nerve, and your vagus nerve. And if you have problems with cranial nerves 9 and 10, eventually your patient would exhibit hoarseness, okay? So they would also have difficulties with swallowing and breathing because of the weakness of the muscles for breathing, and eventually weakness of the arms and legs. So the patient may no longer be able to stand. And this descending paralysis will occur in just a matter of minutes or hours. So it could begin, okay, to develop slowly, and then eventually it could happen and progress, okay? And then it would affect the entire body, specifically the voluntary muscles, okay? So in myasthenia gravis, it's common in both men or above 60 and women below 40. So let's try answering a sample question. Which of the following observations in a client who is seeking consult for muscle weakness are associated with myasthenia gravis? A smile that looks like a snarl. What is a snarl? Snarls like when you are so angry and you want to growl. That's a snarl. So yes, because of the muscle weakness of that occurs on the face. Nasal speech, yes. Swallowed water comes out of the nose because of their difficulty of swallowing. So the swallowing muscles are not coordinated. Yes, that could occur. History of eating honey. You know, botulinum toxicity is the one that occurs after eating honey, because a common source of botulinum toxin would be your honey. And that's the reason why honey should never be given to children below 12 months of age. So a common manifestation of botulism would be facial muscle paralysis, similar to myasthenia. What differentiates it is that you would know that it's due to your botulinum toxin when there's a history of intake of home canned products like honey. So this is an X. Weakness that started from the legs moving up. So this is Guillain-Barré syndrome. Weakness that started from the legs going up in a matter of minutes and hours. That's Guillain-Barré syndrome. Difficulty holding up the head with difficulty breathing. Yes, this could be associated with Myasthenia gravis. So, in most cases of Myasthenia gravis, diplopia and ptosis are the first signs and symptoms. So, the factors that worsen Myasthenia gravis would be menstrual period, infection, surgery and stress, fatigue, illness, and treatment with beta blockers, quinidine, phenytoin, and antibiotics. Now, remember, you have here the word stress. So, sometimes you would expect that the muscle weakness of a patient with Myasthenia gravis could be triggered by a stressful event like going to the dentist. The same stressful event that triggers a dissoniant crisis. So you would know that a patient with Myasthenia gravis or a dissoniant crisis is able to anticipate the effect of the event to their health if they take medications before they expose themselves to a stressful event, because whether we like it or not, we have to visit our dentist at least twice a year. Okay, so in that case, you have to prepare yourself for putting yourself under a stressful situation. So diagnosis of Myasthenia gravis involves Neuro Checks. Okay, when you say Neuro Checks, remember the code RMCBS. So R would be reflexes, M would be muscle tone and muscle strength, CBS would be coordination, balance, and the sense of sight and sense of touch. Okay, IcePack test, on the other hand, when the eyelids are drooping, the doctor would usually place an ice pack for 1 to 2 minutes and then it's removed, and then the doctor will evaluate if there's an improvement or not, because if there's not going to be an improvement, that could mean that they will need to perform further tests to rule out Myasthenia gravis. Now, your EMG, pay particular attention to this, involves inserting a fine wire or a very, very thin needle into the muscles. And sometimes the patient is asked to alternately contract or relax the muscles, and the activity of the muscles is recorded on a screen. Okay? So, if the patient would ask if this is going to be painful, you just have to tell them that there's just going to be a slight sting or stung that they will feel. And then the patient will have to undergo your CT scan and your MRI to rule out other conditions. Okay, and of course, to check on whether they are having pulmonary problems, they will have to perform the pulmonary function test. Okay, now what are the medications that are given to patients with Myasthenia gravis? So first, in Myasthenia gravis, you have a deficiency in acetylcholine receptor sites. Therefore, you have to ensure that the patient's acetylcholine is normal. And so we give medications that will prevent the destruction of acetylcholine, and these are called cholinesterase inhibitors. An example would be pyridostigmine. Common side effect includes excessive salivation, sweating, diarrhea, and nausea. Now, the purpose of your cholinesterase inhibitors is to improve muscle strength and contraction. Now, corticosteroids, example would be prednisone, could be given to limit antibody production. Now, this could lead to weight gain and eventually thinning of the bones that leads to fracture. So it's very, very important for you to note that if the patient's taking steroids orally, you have to administer it with meals to prevent GI irritation. Okay, and of course, since your corticosteroids could potentially cause immunosuppression of the patient, your priority nursing diagnosis should be risk for infection. Then, immunosuppressants like azathioprine or cyclosporine. Now remember, cyclosporine should not be given with grapefruit juice because your grapefruit juice would decrease the absorption of the drug. Okay, it is given to alter the immune response of the patient, and taking immunosuppressants may lead to increased infection, liver and kidney damage. So you always have to check the liver function tests and the kidney function test. Last but not the least would be your intravenous immunoglobulins and monoclonal antibodies. Now, your immunoglobulins are given to the patient to provide normal antibodies. Your monoclonal antibodies like rituximab or eculizumab, these are usually given to strengthen the body's response to the potential autoimmune reaction that develops when myasthenia gravis results. Therefore, you have to remember that your IV immune globulin may cause fluid retention, dizziness, and headache. And this has to be explained to the patient. So once again, these are the 5 classification of the drugs. You have cholinesterase inhibitors, corticosteroids, immunosuppressants, IV immune globulins, and of course your monoclonal antibodies. Now, if the patient with myasthenia gravis would not improve with traditional treatment like administration of medications, then they will have to perform thymectomy. So thymectomy involves removal of the thymus gland. So the thymus gland actually produces antibodies. And you know for a fact that myasthenia gravis could be associated with an autoimmune reaction. So therefore, it's the body's defenses attacking its own. So to prevent that from happening, to stop that from happening, then you have to remove the organ that produces antibodies. And that's going to be your thymus gland. Now, there's a surgery that's called robot-assisted thymectomy, which involves making small incisions on the side of the chest to remove the thymus gland. Okay, so you just have to explain this to the patient that robot-assisted thymectomy has an advantage of, okay, faster recovery, so lesser hospitalization or confinement, and of course, definitely it leads to lesser hospital bills. Okay. So let's try answering a sample question. Which of the following interventions should the RN implement in providing home care for a client with myasthenia gravis? Select all that apply. Now remember that the main problem in myasthenia gravis is muscle weakness. And the more you move your muscles, the more weak they become. So since we have the same muscles that we use for talking and eating, avoid lengthy phone calls before meals. Yes. Because if you do that before meals, eventually the patient would be at high risk for aspiration, because the muscles that they will use for talking are the same muscles that they use for eating. Okay, so we put a check. Install grab bars, yes. Okay, remember you have weakness of the muscles. Use electric toothbrush. Now, what the hell? Why do we need the electric toothbrush? Remember, you have muscle weakness in clients with myasthenia gravis. You have to conserve as much energy as you can. So use all sorts of power-generated equipment like electronic or electric toothbrush to conserve muscle strength. So we put a check. Avoid watching TV. Oh, it's not really a contraindication. Some patients, when they have drooping of the eyelids, what they do is that they put on a patch on one eye and still use the other eye to watch the TV. And then when the eye gets tired, specifically the eye muscles, then they just transfer the patch to the other side and use the other eye for watching TV. So watching TV is not contraindicated. You can ask your patient to continue doing so. Engage in one-time full-day shopping. What is appropriate for them is going to be short, frequent, okay, strenuous activities. So one whole day of shopping is just too much for a patient with myasthenia gravis who's having muscle weakness. So this is not appropriate. Have frequent small meals and avoid raw fruits and vegetables. Why would there be a need to avoid raw fruits and vegetables? They require energy, okay, for mastication, because these foods are raw, and therefore patient will need to exert more effort, and that could worsen weakness. Okay, so yes, those raw fruits and vegetables needs to be avoided, so we put a check. Okay, now what are the common complications of patients with myasthenia gravis? Remember this. You could either have myasthenic crisis and cholinergic crisis, but whether you're having myasthenic crisis or cholinergic crisis, remember, the common manifestation, the general common manifestation would be muscle weakness. So you wouldn't know whether the muscle weakness that has become severe in a patient with myasthenia gravis is due to myasthenic crisis or cholinergic crisis if you don't perform a specific test. So let's talk about myasthenic crisis and differentiate it from cholinergic crisis. Here we go. Here's a functional concept. Muscle weakness may indicate a complication of myasthenia gravis. Okay, so if you have a patient with myasthenia gravis who exhibits weakness that has become severe, note for the cause. It could either be due to too little medication. So if the patient's not receiving enough medication, so which means their acetylcholine could further decrease and the muscles will not react, therefore the muscles would become weak. Okay, and this is what we term myasthenic crisis. Myasthenic crisis is manifested by respiratory failure, so your priority would be ineffective breathing pattern. So always check the patient's respiratory rate, bronchorrhea, excessive mucus production, and then increased salivation, and the heart rate would usually decrease because of muscarinic activation of the muscarinic receptors, which could lead to the reduction of heart rate, meaning bradycardia. Okay? So, in this case, to reverse the reaction, you have to administer neostigmine, because neostigmine is the treatment that is given to a client with myasthenia gravis. And since myasthenic crisis is due to too little medication, then you'll just have to treat it with the medication that's supposed to be given to the patient. Okay, now, what about when the patient has too much medication? You have an excess medication. Once again, the patient would be having weakness. That's why this is what is difficult, myasthenic and cholinergic crisis. So whether you have too little medication or too much medication, there's going to be muscle weakness. So how would you know that it's cholinergic crisis? When, take a look at the manifestation, there's respiratory failure, which also occurs in myasthenic crisis, bronchorrhea, also occurs in myasthenic crisis, increased salivation, also similar to myasthenic crisis, but look at the heart rate here. Initially, the patient will have tachycardia and then it progresses to bradycardia. Why is that so? The tachycardia is due to the stimulation of the nicotinic receptors, which would trigger the parasympathetic and the sympathetic nervous system, triggering now tachycardia. Then eventually, due to the muscarinic receptor stimulation, the patient will also have bradycardia. So, if it's going to be muscle weakness with bradycardia, think about myasthenic crisis, too little medication. If it's going to be tachycardia that progresses to bradycardia with muscle weakness, think about cholinergic crisis, which is due to too much medication. But take note, even if a patient is having muscle weakness in a client with cholinergic crisis, they still exhibit positive deep tendon reflex, which could be 2+ or more. Okay? Now, your cholinergic crisis is managed through the administration of the antidote of neostigmine, and that is your atropine sulfate or one of your oxims. It's called pralidoxime. Okay? So administer atropine and, it's not or, atropine and pralidoxime. Now, if the patient just presents with muscle weakness and you have yet to classify whether it's due to myasthenic crisis or cholinergic crisis, then you perform what's called tensilon test. Tensilon test entails the use of endrophonium hydrochloride, a short-acting, cholinesterase inhibitor, which means your tensilon increases the level of your acetylcholine. So, the disadvantage of tensilon, that's why it cannot be used as a form of treatment, is that it has a short duration of action. So, the action fades after 5 minutes. So, if you use this as treatment, you'll have to ask the patient to take it every 5 minutes. That's not a very good routine to do, taking medications every 5 minutes. So, this is just used for diagnostic purposes. So, if the patient comes in with muscle weakness, you give tensilon. Remember, tensilon acts like your neostigmine. So if tensilon relieves muscle weakness, then the patient's having myasthenic crisis. Because what you have in myasthenic crisis is too little medication. You're adding tensilon, which is a form of medication. So if tensilon relieves muscle weakness, that's myasthenic crisis. However, If tensilon worsens muscle weakness, that's cholinergic crisis. Because remember, cholinergic crisis is due to too much medication. So muscle weakness that is relieved by tensilon is due to myasthenic crisis. Muscle weakness that is worsened by tensilon is due to cholinergic crisis. Now, this is another thing that I made to highlight this thing. You would notice that on your left-hand side, myasthenic crisis is due to too little medication is represented by a pale orange color. Just to remind you, it's due to too little medication. And your cholinergic crisis on your right-hand side is actually written in a red font. That's just to highlight that it's due to too much or over medication of the patient. Clever way to do it. Simple but clever. Just for you guys. That's how much I love you. I would exert additional effort just for you to remember this. Okay? So whether your patient is having myasthenic crisis or cholinergic crisis, the priority would always be respiration, because in both conditions your patient would be having respiratory failure, and since there's increased salivation, they are also both at risk for aspiration. Okay, so remember, here's a functional concept. Muscle weakness with bradycardia may indicate myasthenic crisis in a client with myasthenia gravis, and it has to be managed with the administration of neostigmine. On the other hand, muscle weakness with tachycardia that progresses to bradycardia may indicate cholinergic crisis in a client with myasthenia gravis and should be managed with your atropine and pralidoxime. Okay, so remember, in cholinergic crisis, sludge syndrome occurs. Sludge is actually an acronym for a group of symptoms like salivation, lacrimation, urinary incontinence, diarrhea, GI upset, and emesis. Now, even if these could be present, it is not something that's present in all cases of cholinergic crisis. So sometimes it could only be 3 of these, 4 of these, 5. Okay, but in some conditions, all of this could be present. So it's called sludge syndrome. Once again, salivation, lacrimation, urinary incontinence, diarrhea, GI upset, and emesis. Okay, way to go. So here's a feedback from one of our participants, our viewers, Catherine, and she says, no dull moments with your lecture, Sir. You explained it in simple terms and easy to understand. Thank you for sharing your talent. May God bless you for your generosity and kindness. And of course, somebody also said, thank you so much, Dr. My heartfelt gratitude for all of this, especially receiving the blessing of having a new lease on life. Thank you so much, dear colleagues. And this is the impetus that has kept me going and helping out nurses achieve their great American dreams. That is to practice in the U.S. through my YouTube channel. And I just hope you keep on supporting us so we could actually help more of our colleagues. Now let's talk about a light topic, hospice care. So hospice care, here's a functional concept, involves provision of care for people in the last phases of incurable disease. Like if your doctor has told you that you have 6 months more to live, then you could be placed in hospice care, in which the focus would be giving you, lessening the pain in your last few months and giving you the best care you deserve so that you have a dignified death. So it's not about postponing death. Okay, the philosophy of hospice care is that they acknowledge that death can occur anytime, but they make sure that the person under their care is comfortable through the help of various professionals. So let's try answering a simple question. Which of the following statements about hospice care are true? Select all that apply. Begins in the early stages of a disease? No, we just said that it begins when you are found to be having like the last 6 months of your life because you are suffering, you are in the end stage of your condition. So this is an X. It is implemented by a team of professionals. Yes, we said that a while back. It leads to a dignified death. Yes. It tries to postpone death. No. It is anchored on the recovery mindset. No. When you put a patient on a hospice, your focus is not really on the recovery of the patient, but on making it comfortable for the patient in the last remaining days of his life. So this is an X. And it includes the client's family? Yes. Okay. Now, let's talk about GERD, gastroesophageal refluxes. This is the #1 gastrointestinal problem among Americans. Okay. Now, this is how the normal stomach looks like. Okay, so this is from Creative Commons also. Okay, so you have your lower esophageal sphincter that prevents the backflow of stomach contents into the esophagus. Okay, and the stomach content, after 2 to 3 hours, moves on to your small intestines, the duodenum, the jejunum, and then the ileum. Now, what happens when your lower esophageal sphincter relaxes? So there's going to be a backflow of stomach acids, and this could lead to a sensation of like a burning sensation near the heart. That's why it's called a heartburn. Now, if this happens continuously, eventually the lower esophageal area becomes eroded, and that leads to a condition known as Barrett's esophagus. And Barrett's esophagus increases the risk for the development of cancer. Okay, so here's a functional concept. GERD is acid reflux that occurs regularly. A mild form occurs twice a week, whereas a moderate to severe form occurs once a week. So GERD is manifested by, remember, GERD, gassy or burning sensation on the chest, extra lumpy throat sensation, or sometimes they would have a throaty feel, or they would feel discomfort in their throats, regurgitation of food, and difficulty swallowing. So GERD. Risk factors to GERD, remember the code HOPS, okay, which means this could occur with hiatal hernia, obesity, so definitely you ask a patient to lose weight, pregnancy, because the pregnant uterus could push on the stomach, and then eventually causing stomach contents to regurgitate upwards into the lower esophagus, and then stomach emptying that is delayed, and of course in clients with scleroderma, okay, which could be an autoimmune condition. Now, factors that aggravate GERD includes here's your code, SIL, smoking, eating fatty foods. Why is that so? Because fat delays emptying of the stomach. So if you have high fat in your stomach, eventually the acid stays there a little longer, and when backflow occurs, then heartburn results. And then alcohol, which relaxes the lower esophageal sphincter, and of course aspirin, and large meal or late night eating. So those of you who love to go on midnight snacking, you will aggravate the symptoms of GERD. So nighttime acid reflux may lead to chronic cough, laryngitis, asthma, and disturbed sleep. Now, eventually, the patient's voice could become hoarse because of the esophageal reflux. So the diagnosis for GERD involves your upper endoscopy, a pH probe, specifically of the reflux. If it's acidic, it's coming from the stomach, esophageal manometry, and upper GI X-ray, including your barium swallow. Okay. So what are the medications that are given for GERD clients? You have antacids like Mylanta to neutralize stomach acids. You have your H2 receptor blockers like cimetidine and famotidine to reduce acid production for longer relief. However, intake of H2 receptor blockers may lead to vitamin B12 deficiency, leading to pernicious anemia. Your proton pump inhibitors or PPI, lansoprazole or omeprazole, esomeprazole or omeprazole. These medications are used to block acid production and heal the esophagus. Once again, like your H2 receptor blockers, it could also lead to vitamin B12 deficiency, and because of the thinning of the bone, could lead to hip fracture. And of course, your skeletal muscle relaxant, your baclofen, sometimes is sold under the name Lioresal, okay, which is given to decrease reflux and strengthen the lower esophageal sphincter. So take note that your baclofen may cause nausea or fatigue. Now, in clients with GERD, there's a surgical intervention called laparoscopic fundoplication, in which the lower part of the stomach is attached to the lower esophageal sphincter to reinforce it, to strengthen it. So that would, in essence, create constricting effect on the lower esophageal sphincter, preventing now the backflow of your stomach contents. So remember, GERD is manifested by the code GERD, HOPS, always remember, GERD, HOPS, seal, clad. Okay? GERD, HOPS, seal, clad. Now, sometimes the problem is we remember the code, but we forget what they mean. Okay. So you have to make sure that you remember the code and remember what I mean. Okay, so let's try answering a simple question. So which of the following statements about gastroesophageal reflux disease is true? Weight loss can help improve the symptoms. Yes. Sitting upright after meals decreases heartburn. Yes. So it's appropriate for them to sit upright, read a book after meals. Okay, that would help. So reading books after meal times could help in patients with GRD. Not just reading books, reading magazines or reading newspapers, whatever there is that would keep them upright. Okay. GERD may disrupt sleep. Yes. Smoking may help relieve symptoms. No. It could worsen the symptoms. It does not progress to cancer. Remember we said a while back that GERD could lead to Barrett's esophagus, which could potentially lead to cancer. So we put an X. Small frequent meals may help decrease the symptoms. Yes. Okay. So another thing that I'd like to highlight in this quick fix number 20 would be vitamin B12 deficiency anemia, or otherwise known as pernicious anemia. Now, pernicious anemia could be a result of a lot of factors. We know for a fact that the absorption of vitamin B12 is facilitated by the presence of the intrinsic factor in the stomach. So if you are aging, okay, the stomach atrophies, diminishing your intrinsic factor, leading to decreased absorption of vitamin B12, that would lead to pernicious anemia. Okay, so the patient would usually have tingling sensation in the fingers and the toes. Okay, and then the signs and symptoms of anemia, which is fatigue, pallor, fainting, and forgetfulness. Okay. Now, what happens also when a patient is post-gastric surgery? Once again, the intrinsic factor is diminished. Therefore, there's going to be decreased absorption of vitamin B12. So remember, vitamin B12 could be best sourced from animal sources of protein. Okay, like your meat, your egg, your milk. Okay, poultry products. Your plant products may not necessarily contain vitamin B12. So if you talk about the vegetarian patient, they are at risk for vitamin B12 deficiency. And there are religious sects, okay, that do not eat meat. And so they are at risk for vitamin B12 deficiency. Okay? So deficiency in vitamin B12 leads to anemia. Vitamin B12 is found in cereals, meat, cheese, yogurt, shellfish, eggs, and meat. Deficiency in vitamin B12 can be related to aging, gastric surgery, diabetes, thyroid disease, Crohn's disease, celiac disease, or even tapeworm. The presence of malabsorption syndrome in the gastrointestinal tract. Deficiency in vitamin B12 can lead to tingling in the hands and feet, impaired balance, confusion, and forgetfulness. Therefore, you have to instruct the client to increase intake of meat, eggs, and meat because they contain vitamin B12. So, with the knowledge, let's now use that to try to answer a simple question. Which of the following clients are at risk for pernicious anemia? Told you a while back, a client who is vegetarian, okay, could be at risk. 68-year-old frail elderly, yes. Aging is a risk factor. A 50-year-old post-gastrectomy, yes. 35-year-old who always overcook his food. If you overcook food, you are diminishing the folic acid content. So that leads to folic acid deficiency anemia, not pernicious anemia. So we put an X. 25-year-old pregnant client. Now, once again, this is associated with folic acid deficiency anemia, especially if they're not eating green leafy vegetables because they need at least 400 micrograms of folic acid per day if they're pregnant. So we put an X. 35-year-old with Crohn's disease, yes. Okay. Crohn's disease, you could have malabsorption of vitamins in the gastrointestinal tract. So that's a risk factor for the development of pernicious anemia. Now, there are other vitamin deficiency anemias, and this may include folate or B9 deficiency, which could occur because of deficiency in the intake of fruits and leafy green vegetables. Who are at risk? Once again, take note, the pregnant women, those with celiac disease, those who are alcoholic or on anti-seizure drugs. The treatment would be to supplement them with folate, they would need 400 micrograms per day. Or you can increase the source of folic acid in their diet, like nuts, bread, cereals, pasta, dark green leafy vegetables. Don't forget, dark green leafy vegetables is rich in folic acid. Now, vitamin C, which is also important in the formation of red blood cells, without which the formation of red blood cells decreases. Therefore, the patient will have vitamin C deficiency that could aggravate anemia. So there's deficiency of vitamin C due to smoking, cancer, or chronic kidney diseases, and therefore who are at risk. Remember, some, the smoker, the alcoholic, and those with malabsorption conditions. Now, remember the fact that vitamin C is easily excreted from the body, but it's very essential in order for you to fight infection. It could even strengthen the teeth. So if you have vitamin C deficiency, eventually the teeth could also be affected. Okay, so vitamin C requirements would be 75 to 90 milligrams per day. So you just have to increase sources like broccoli, citrus fruits, strawberries, and tomatoes. Okay, now let's talk about pyloric stenosis. Now, once again, this picture came from Creative Commons. So when you say pyloric stenosis, what happens is that the area where you have the pyloric sphincter thickens. So what happens now, the pyloric sphincter is a muscular structure that is located between the stomach and the lower intestines. Okay, so if you have a thickening of the pyloric sphincter, the patient will exhibit an olive-shaped mass. And eventually, after several days after birth, when they are fed, they exhibit projectile vomiting, in which, due to the pressure inside the GIT, the vomitus could be projected with a distance of up to 3 to 4 feet. Okay, so that's how far the vomitus could get. Okay, so it's like having something inside the balloon, then pressing it, then eventually it pops out and it moves up in a laser trajectory manner. That's how it goes. Okay, so pyloric stenosis is due to the thickening of the pyloric sphincter. It can lead to projectile vomiting, dehydration, and weight loss. So take note that your pyloric stenosis causes PD CLAPS. That's a code. Projectile vomiting, sometimes when it occurs too frequent, then the vomitus could contain blood. Then, because of the vomiting, the patient will have dehydration, constipation, loss of weight, and abnormal stomach contractions with persistent hunger. Because even if they are eating, they're vomiting it out. Then eventually, you will notice the presence of an olive-shaped mass upon palpation. So the signs of pyloric stenosis does not occur after birth. Instead, it becomes evident 3 to 5 weeks after birth. So it's not immediately after birth, several days to even weeks after birth. So pyloric stenosis can be diagnosed through X-ray, and the surgical procedure is pyloromyotomy. Okay, that's a surgical treatment for pyloric stenosis. So let's try answering a sample question. The RN is providing discharge instructions to the mother of a child post-pyloromyotomy. Which information should the nurse include? Vomiting will immediately disappear. No, it won't. Okay, it would take time. And intravenous fluids will be provided. Yes. Okay. Feeding can begin in 24 hours. Actually, feeding can begin as early as 2 hours after surgery. Okay, they usually administer water, and then that progresses to milk after another 2 hours. Then that progresses to semi-liquid foods. Okay, so what happens is that within 24 hours, the baby could be fed. So this is correct. So bleeding is expected after surgery. No, bleeding is indicative of a complication. Infection is not a possible complication. It is a possible complication, so that's an X. The baby may become hungry more often. Yes, because eventually what they have in their stomach is now being pushed down the small intestines. Now, this is one thing I'd like you to remember, guys. ROGAM. And ROGAM should be remembered in relation to your RH incompatibility. Now, we have a separate video on this, and those of you who have yet to subscribe and you're watching our video at this point, please do hit that subscribe and bell notification button so you get notified when we're uploading videos every week. And If you share it to at least 10 of your friends, then you will spend minimal time in answering the minimal number of items and pass the test. Okay? So ROGAM is given to prevent RH incompatibility. So with that, you have to remember about blood types. Like blood type A, the compatible blood would be A and O. For blood type B, compatible blood would be B and O. For type AB, compatible blood would be type A, B, AB, and O. And for type O, compatible blood would be O only. Now remember, those with blood type A, B, AB, and O can all receive type O blood. And those with blood type AB could actually be given type A, B, AB, and O. But a patient with type O can only receive type O. That's why it's called type O is the universal donor, whereas blood type AB is the universal recipient. Now, on to the RH status. Okay, remember the functional concept. An RH positive blood can be mixed with an RH positive and negative blood, whereas an RH negative blood can only be mixed with an RH negative blood. So where is the problem? If the mother is RH positive, remember the functional concept I told you a while back, their blood should only be mixed with an RH negative blood. So the problem occurs if the mother is RH negative and the baby becomes RH positive. Okay, there's no problem if the mother is RH positive because their blood could be mixed with both either positive or negative blood. Okay, so let's move on. RH incompatibility develops when the mother is RH negative and the baby is RH positive. So let's check ROGAM. It's an anti-RH medication. Remember this, it's given in RH negative women with RH positive babies. It's for prevention of RH immunization, and given at 28 weeks of pregnancy and at 72 hours after delivery when there is bleeding after procedures like chorionic villi sampling or amniocentesis, and there is RH incompatibility that is being ruled out, then, or the patient's having threatened abortion, then you have to administer ROGAM. So it's not indicated in patients with anaphylactic reaction to ROGAM. It's not indicated if the mother is negative, RH negative, and the baby is RH negative. Okay, they are compatible. It's given when the mother is RH negative and the baby is RH positive. So it's indicated in transfusion of RH incompatible blood when there's abortion or threatened abortion, or when there is placental hemorrhaging, when pregnancy or delivery of an RH positive baby occurs, and when there is ectopic pregnancy, and after diagnostic procedures like amniocentesis, chorionic villi sampling, and percutaneous umbilical cord blood sampling, which are invasive and may potentially cause bleeding. So therefore, your ROGAM has to be ready. So your code for that would be taped. Okay. Now, it's administered, your ROGAM is administered IM only to the mother, and it's not injected to the newborn. So let's try answering a sample question. Which of the following blood types can be administered to a client with RH positive type AB blood? So you have to mix the blood type and the RH state. The fact that the mother is RH positive, what did we say? You can mix an RH positive blood with both positive and negative. Okay. Next concept, you have a blood type AB. What did we say a while back? Blood type AB is the universal recipient. They can receive A, B, AB, and O. So in essence, since you have RH positive and AB blood types, so they can receive all types of blood actually. Okay. Okay, that's the way to do it. Now, let's talk about your antisocial personality disorder. Remember this, class. Antisocial personality disorder, people with personality disorder are not considered as psychotic. Okay? They are in contact with reality, but they have rigid, okay, patterns of interpersonal functioning. So which simply means their reality testing is intact. They're in contact with reality. Their problem would be impaired decision making. You would see antisocial patients because they know they can use their charm to get away with what they want. Even if they don't have any money to pay the electricity bills, they would buy new appliances and eventually ask a girlfriend to buy it for them. because they know they can use their charm to get away with it. But in most histories of patients with antisocial personality disorder, there's usually a diagnosis of conduct disorder before age 15. So if you notice that a person is cruel to animals, chances are then they could be at risk for developing antisocial personality disorder. So the main problem in antisocial personality disorder is ingrained in the personality of the person. That's difficult to change. You cannot modify the personality. You can only modify the behavior. And that's all there is to it. Okay? So a patient with antisocial personality disorder habitually breaks the law, acts impulsively. They don't think, ignores the rights and feelings of others, and they're cruel to animals and have no guilt or remorse. Okay? So, if your boyfriend or girlfriend is kind to animals, they could be good partners. But if they're not kind to animals, then think twice. Okay? Well, I'm not saying that if you have met somebody whom you think just perfectly matches you, okay, and then eventually they are cruel to animals, and you would say, oh, there's a potential antisocial personality disorder. I'm not saying that. What I'm trying to tell you is you have to be very, very cautious, because some of us could be very, very hopeless romantic, and you fall into the nostalgic feeling of being in love when you get to see somebody who reflects all of what is ideal for you. Okay? Because this is their way of manipulating you. They try to put a good front just to show you. They use their charm to entice you. And where you're into it, that's when the cruelty begins. So this is a lifelong disorder. It won't go away. So your option is just either to live with them or leave them. Okay? So genes increase one's vulnerability to develop antisocial personality disorder. So a history of conduct disorder before age 15 increases one's risk to develop antisocial personality disorder. Spouse abuse or child abuse or neglect can result from relationships with a person with antisocial personality disorder. The diagnosis of antisocial personality disorder is based on how the person relates with others. Now, the treatment of choice would be psychotherapy to improve the symptoms. Let's use that knowledge from the functional concepts to answer a simple question. A client with history of truancy seeks help for anxiety and depression. And remember, patients with antisocial personality disorder, they don't think that something is wrong with them. So they would consult for other psychological problems like anxiety and depression. Okay, which of the following indicate possible antisocial personality disorder? Exploits others? Yes. Sexually promiscuous? Yes. Attention seeker? The attention seeker is labeled as a person with histrionic personality disorder. Socially withdrawn? This is the schizoid personality disorder. Fierce interpersonal rejection? This is the patient with borderline personality disorder. So we put an X. So you only have 1 and 2. You can add cruelty to animals. Okay. Now let's move on to perineal hematoma. So it is due to collection of blood beneath the skin in the perineal area or beneath the vaginal mucosa or in the broad ligaments. Remember, perineal hematoma that is large causes pain and needs to be drained. So let's try answering a sample question. Which of the following interventions for perineal care are appropriate to provide a postpartum client? Avoid using tampons after delivery, yes. And it's more important to use the low absorbent tampons than the high absorbent tampons, because if you keep using high absorbent tampons, then there's a tendency for you to leave it in place for more than 8 hours. That increases your chance of developing toxic shock syndrome, which could be due to infection with Staphylococcus aureus. So to prevent that from happening, use the low absorbent tampons that would require you to change it every 4 hours. Okay? Avoid sexual intercourse until the pain subsides. That is correct. Report spotting, severe pain, and foul-smelling discharge. Yes, that could be a sign of infection. High fever is expected. No, high fever is indicative of infection. Avoid using water-soluble lubricant during sexual intercourse. No, it's appropriate to use that. okay, to decrease the pain. Immerse the buttocks and hips in either cold or warm water once or twice a day. This is called a sitz bath, okay? So that is allowed. Okay, so at this point in time, I would like to tell you this. Work hard, stay disciplined, and be patient. Don't forget, keep doing your best because your time will definitely come. Believe. That's what matters the most. So, once again, I'd like to invite you in my 45 days Power Pack exclusive NCLEX-RN test preparations review. That starts on September 11. Well, all seats are taken for the one that starts in July 12. All seats also are taken for the one that starts in August 16. September 11 is the next, and it's called the NCLEX exclusive virtual bootcamp with Ray Gapus. And the time is going to be from 9 a.m. to 1:30 p.m. Philippines and India, and 6 p.m. to 10:30 p.m. for clients in California. So it covers all the functional concepts and trends, as well as updates utilizing an all-new method of instruction and technology tools that I created myself. So the package includes all learning tools, including 3 books. Courier fees for the books are excluded. To register, please send us an email to grab a slot. Okay, so this is the end of session 20. If you have any request, let's learn together. You can send me your request through email, mentor.raygapus@gmail.com. So remember, a functional concept a day keeps your NCLEX-RN fears away. This is your mentor, Ray, your fact check buddy, saying thank you for joining me. Believe that you can and you will. See you next time. So if you love this video, please don't forget to subscribe, share, and hit the like and bell button.